Thank you so much for that nice introduction. It is really a pleasure to be with you this morning, talking about sensory health, and I just want to thank the organizers for putting this on the program. All right, so I want to start by having us immerse a little bit in an appreciation of our vision function. So this is a bunch of images that try to simulate what vision looks like with various eye conditions. And you can take sort of any one of these images and just, for a moment, picture your life if this is how you saw the world. What would be the limitations you might face? What would be the things that you enjoy that maybe you would have to adapt or wouldn't be able to do? Just take a moment to think about, how much your vision does for you and how important it is to your quality of life. Okay, so that's a little bit of an individual perspective on the impact of vision loss. Now let's turn a little bit to the literature. So right up here, if I can make this pointer work, sort of. Okay, we're gonna maybe forget the pointer. Is a framework developed by Swainer et al. Showing the relationship between vision loss and various domains of functioning and how that then leads to various outcomes. And really, vision loss and generally sensory impairment impacts really all the domains of functioning. If you can't see your environment, it's really hard to get out and be physically active. If you can't drive at night or drive at all because of vision loss, it's hard to engage in social activities, many of which take place out of your home at night. Of course, not being able to do the things you love to do impacts your emotional well-being. And then finally, through these pathways and others, we have an impact on our cognitive health. And in fact, the literature at this point has gotten strong enough showing the relationship between vision loss and cognitive impairment that it's now included in the most recent Lancet report on dementia prevention as one of the 14 factors that can be intervened upon that we can work on to lower the risk of dementia. And hearing loss, I'll just note, was actually included in the previous report, so both of those are now listed as intervenable factors. So is vision loss really intervenable? Yeah, this is low-hanging fruit. So about 80% of the vision loss that we see in aging adult populations is due to refractive error. So this is what we can correct with glasses and contacts. People just don't have access, or they're not updating their glasses and contacts because they don't think it's an important part of their life. Amongst the other 20%, about half of that is cataract. We have an extremely effective and cost-effective intervention for cataract. So we're talking about 90% of the burden of vision loss in aging adults that we can correct if we just have the will and the resources and put a little funding towards it. Okay, I may have clicked twice. We'll see if it moves on. Okay, so in 2017, we started thinking about vision loss and eye health in adults aging with HIV and what the current picture was. A lot of work had been done about 20 years ago looking at LSOCA, which was really based on individuals living with AIDS. So in an immune-suppressed context, what do we see in terms of eye health? A lot of HIV retinopathy, but this is really not where we are. We're now looking at aging adults, so these are people who are getting into ages where we see an increased burden of eye disease and vision loss, but also these are long-term survivors now who have had suppressed viral loads for many, many years. So is HIV really having an impact on eye health in this community? So the simplest thing to do, of course, is just to ask people about their eye health. So we put in a modified version of the NEI VFQ, NEI, National Eye Institute, VFQ, Vision Function Quality of Life. And this just asks people, we chose 6 questions that get at their vision difficulty around various vision-related tasks. How much difficulty do you have reading text? How much difficulty do you have doing near hobbies? How much difficulty do you have driving? So we asked this of about 1,000 men living with HIV, aging with HIV from the MAX study, median age around 65, and about 95% of them were virally suppressed. So what did we see? Well, the prevalence of reported vision difficulty of at least a little, but it could be moderate or severe, those are the gradations of colors there, was around 10 to 40%, depending upon which task we asked them about. And then really for any task, as you can see, the individuals who are aging with HIV reported about 5% higher burden of vision difficulty on any given task. So sort of when you summarize across that, you see that men aging with HIV reported moderate to extreme difficulty on at least one task. About 21% of them are reporting that, compared to about 13% for men who were aging without HIV, just suggesting that there is this higher burden of at least perceived vision difficulty. But of course, perceived vision difficulty is an objective vision loss. It may correlate with objective vision loss, but it could also be due to a number of factors that sort of influence how people perceive their vision ability. However, what we do know is that in general, people aging with HIV report vision issues as being important to them. So this is from the 2021 Colorado statewide coordinated statement of need on HIV/AIDS prevention and care. And vision issues were reported by 21% of the respondents as being the top non-HIV concern, health concern. And that would lift it right up there with loneliness and dental issues. So people aging with HIV do feel that their vision is important, and this could be because they're experiencing more vision loss, or it could be because that vision loss is just more impactful in their lives. So we also looked at the correlation with various outcomes, and what we saw was pretty much everything we looked at, various comorbidities and also functional decline, was related to the degree to which people reported vision difficulty. So you can see each of those trends is sort of consistent across people who are aging with HIV and people who are aging without HIV. So this really got us thinking about, what are the mechanics underlying those relationships? This is all cross-sectional data. We don't know, but we wanted to really look into healthcare engagement, because one idea is that people who are experiencing vision loss really have a harder time engaging in their healthcare, and that may contribute to various outcomes. And there's lots of reasons to think that vision loss may contribute to a lack of engagement in care. It may be hard to get to doctor's appointments. So if you can't drive, it's much harder to get to those appointments. If you look at pill bottles, they are always written in about size 4 font. That can be really hard to read for people who are experiencing near vision loss. And then just absorbing health information. They may not have the greatest access to health information about any particular condition. So we wanted to look at this with the data in the MAX. So we sort of combed through the data to find indicators of engagement and care. And we found a few things. One was ART adherence, which I think is a pretty good indicator of engagement and care for people living with HIV. We also found questions about healthcare avoidance, and then asking questions of your care provider. And finally, just looking at quality of life, which is important. So what did we find? Well, there were pretty good associations between reported vision difficulty and a poor adherence. As you can see, the prevalence of poor adherence goes up with more extreme vision difficulty. You see the trend sort of less strong here with avoiding necessary care, but definitely a difference between people reporting no difficulty and those reporting at least a little difficulty, with higher prevalences of avoiding health care amongst those who have at least a little difficulty with their vision. Asking questions, there wasn't really a strong relationship. Oh, sorry. I don't know how to go back. There we go. But the quality of life had pretty strong relationships, with lower scores reported for those who experienced more vision difficulty. Now, I want to touch on this quality of life piece because it was really more nuanced than these numbers show. So right here, I'm going to attempt my pointer again and fail. Right here on the top, you can see the quantile. So these are the percentiles from 10%, 50%, and 90%. And what you notice is that the bars, which show the difference in quality of life between people reporting no vision difficulty and those reporting at least some level of difficulty, a little or moderate and extreme, that's the dark gray and the light gray. You can see for people who are on the high end of the quality of life spectrum, so these are the 90 percentile folk, they're doing well. Their quality of life is great. And so if they experience some perceived vision loss, it really doesn't affect them, right? They're just doing okay. But on the other end of the spectrum, people at the 10th percentile, so these are people who are reporting really poor quality of life. And for these individuals, having vision loss is really impactful. It really lowers their quality of life scores. So the nuance here is that if you're doing well, then vision loss may not be that important. But if you're doing poorly, it sort of serves as a second hit. It's another thing you have to deal with, and it just decreases your quality of life. And I'll just add that we saw sort of the same nuances when we looked at social connectivity. People who have more individuals in their life, family and friends that they can rely on for help, they tend to be less impacted by vision loss. People who have no one they can rely on do worse. And this makes a lot of sense. It's easier to get to appointments, doctor's appointments, if you have somebody who can drive you there, if you have somebody who can read your pill bottles, who can explain health information. This all makes it much easier to live with something like vision loss. Okay, so, all of this data is subjective. We really wanted to get some ideas about objective vision loss and eye health. So we implemented a small pilot study, the HIV vision study. This kicked off in 2021, which of course, as everybody here knows, was awful timing because this is during COVID. So we only were able to recruit about 154 individuals from a single site from the MWCCS. This is both men and women aging with HIV. And we brought them to the Wilmer Eye Institute and did a battery of eye examinations on them. So what did we find? So the prevalence of eye pathology really was pretty rare in these individuals, as would be expected for people who are mean age of 68. So that's starting to get to the ages where you see a higher burden of vision loss and eye disease. But, it doesn't start to skyrocket until you get into even older age groups. So we saw sort of lower burdens of vision loss, lower burdens of a lot of eye pathology. However, when you look at the things that we measured, distance visual acuity, near visual acuity, uncorrected refractive error, you see that across the board, people aging with HIV just have a higher prevalence. They are experiencing a higher burden of vision loss sort of across the board. It's not a big difference, but it's there. And then in terms of eye pathology, the big winners here were really dry eye disease, which is a condition that doesn't impact your vision ability that much, but it's just miserable. It really impacts your quality of life. And we saw just incredibly high levels of dry eye disease in individuals aging with HIV, but also their counterparts aging without HIV. And I'll just note this was all age matched, so age does not play a role here. The other thing we saw was really history of cataract. People who are aging with HIV just seem to have a higher burden of cataract, and they're getting more cataract surgery. So does HIV matter for vision health sort of in a modern context? I think the accumulation of what we're seeing indicates yes, with an asterisk that clearly more work is needed. But we saw that there's just a higher burden of self-reported difficulty. More people aging with HIV are reporting that they're having vision issues. Those vision issues seem to be affecting their ability to engage in healthcare. It seems to be impacting their quality of life. And then even though, objective vision impairment is relatively low, you saw sort of a consistent trend of higher vision impairment in people aging with HIV and a higher burden of uncorrected refractive error, which has implications for access to sensory care. And then finally, just this massive burden of dry eye that I think we really need to look more at, and a higher burden of cataract. Okay, so I'm sure I'm running out of time, but I just want to touch on some qualitative work that we've done recently. So we partnered with a community center that does HIV services, and they're starting to do aging services for adults aging with HIV in the Colorado area. They have about 5 offices throughout Colorado. And we recruited individuals who were 50 years and older living with HIV, who were attending their healthy aging programs. We invited them to engage with us in interviews and focus groups, really with the aim of understanding their perceptions of sensory health, but also the facilitators and barriers for accessing sensory health and for using sensory aids. So these would be glasses and hearing aids. And we heard some really interesting things. So first, these are really curious people. Like, they are engaged with health information around HIV, and they want to know, are the sensory changes that they're experiencing, and almost everybody is experiencing sensory changes, are they related to HIV, or are they related to aging, or is it both? So it just sort of speaks to the complexity of aging with HIV. You have curious people who want to understand and want to do something about their health as they age, but they don't know sort of what are the underlying factors. We also heard that there's a lot of internalized ageism around sensory aids, particularly hearing aids. So many of our participants reported that hearing aids and reading glasses to a lesser extent make them feel old. And of course, vanity also played a role. They want things that are accessories. They want them to look good. This was a big factor. You know, we tend to, I think, discount the extent to which vanity should play a role in health, but turns out when you're talking about something that you have to wear, if it's an indicator of your aging, that's not okay. These are vibrant people, they're in their 70s, but they feel young, and that's great. So we need to think a lot about design of sensory aids to make sure that they don't tick off this internalized ageism and sort of vanity piece. And then finally, people who are avoiding sensory aids are adapting. They're doing creative things to try to get around their sensory loss. They are using magnifying glasses. They have one in each coat pocket. They're hanging flashlights all around their house. They are using technology. They are figuring out the best place in the room to stand so they can hear their conversational partner. They are being really creative. The problem is they're avoiding using sensory aids that we know really work. So what are the challenges to sensory care? Certainly the internalized ageism piece has to be addressed. We have to think about the design of hearing aids to make sure they look cool. A bunch of people were using the Apple AirPods. The Pros have really nice hearing aid features. People are choosing these instead of traditional hearing aids because, again, everybody walks around with the Apple AirPods hanging out of their ears. Cost and insurance complexity. You know, bifocals can cost around $800. Hearing aids can be $3,000 to $6,000. So even when you can figure out a Medicare Advantage plan that will cover some of it, it doesn't cover all of it. And these are prices that are just out of the range for many of the participants that we talk to. And of course, just figuring out the insurance is really hard. HIV stigma in healthcare is unfortunately alive and well. We heard story after story. And what this means is that our participants really want to have care, and that's sensory care or any kind of care, from people they trust who understand HIV. They want to go to an ophthalmologist who has a background in HIV because they know that person will understand their experience, will be sympathetic. And lastly, there's just a need for tailored support. We have to think more about how we engage our patients to offer them both warmth. They desire caring. They desire somebody who really, wants to help them, but also navigating the complexity of their health care. Sensory loss exists on top of a whole range of other issues, comorbidity, polypharmacy. So they want somebody who's going to support them and help them navigate all that complexity. Okay, I just want to acknowledge the huge team of people that helped with all of this work. You can't do anything without a team, and this is certainly true in our case. I want to acknowledge our funders, and I think we're going to have a panel later for questions. Thank you so much for your attention.
Yeah.